Cardiovascular disease is the leading cause of disability and death in the United States. This means it affects millions of people every year and has a huge impact not only on lifespan, but also on quality of life. When someone develops cardiovascular disease, their ability to perform daily activities often becomes limited, which affects independence and overall well-being. There are risk factors we cannot change like age, genetics, and family history, but there are also risk factors we can control, such as diet, physical activity, smoking, and stress. That's why education is such an important part of both prevention and treatment. By teaching patients about risk factors, lifestyle changes, and treatment options, we can empower them to take steps that improve heart health and prevent complications. Arteriosclerosis refers to changes in the walls of the arteries and arterioles. Over time, these blood vessels thicken, lose their natural elasticity, and may even become calcified or hardened. This makes it harder for blood to flow smoothly, which increases strain on the heart. You can see in the image here, the normal artery has a wide open space for blood to move through. But in the atherosclerotic artery, there's buildup inside the wall that narrows that opening. This narrowing can lead to serious problems such as chest pain, heart attack, or stroke. One of the most common results of this process is coronary artery disease, or CAD. CAD develops when the arteries that supply the heart muscle with blood become narrowed or blocked. Risk factors for CAD can be divided into two groups: non-modifiable factors like age, gender, and family history, which we cannot change, and modifiable factors such as smoking, diet, physical inactivity, and high cholesterol, which we can change. Patient education is key to helping people manage the risks they can control. An excellent predictor of MI risk is the LDL particle number. It is measured directly or indirectly as a polypoprotein B, the protein particle in each LDL. A high LDL particle number with a low LDL still creates a high risk for MI. The amount of cholesterol contained in each LDL particle varies. Apolipoprotein B particles in LDL-type cholesterol are able to infiltrate the arterial wall, rapidly causing damage. C-reactive protein, CRP, can indicate low-grade inflammation in blood vessels and an increased DIAD risk. Therapeutic interventions include eating heart, healthy diet, dietary approaches to stop hypertension, not smoking, exercising, and taking lipid-lowering agents. Angina pectoris is the medical term for chest pain that happens when the heart muscle does not get enough oxygen-rich blood. This is a symptom of ischemia, meaning the tissues are starved of oxygen. The pain can feel like pressure, squeezing, or heaviness in the chest, and it may spread or radiate to other areas such as the neck, jaw, shoulder, arms, back, or even the upper stomach area. The diagram here shows some of the most common places where patients may feel the discomfort. The most classic radiation is to the left arm, but it can also move to the jaw or back. Causes of angina include coronary artery disease, where narrowed arteries reduce blood flow, vasospasm, which is a temporary tightening of the arteries, valvular heart disease, long-standing hypertension, and heart failure. It's important to remember that angina itself is not a disease. It's a warning sign that the heart is under stress and not receiving enough oxygen. There are two main types of angina: stable and unstable. Stable angina happens with moderate exertion in a familiar pattern. Patients often describe it as chest discomfort that comes on with activity, such as walking upstairs or exercising. The key feature is that the pain is predictable, and it usually goes away with rest or sublingual nitroglycerin. This type of angina is a warning sign that the heart's blood supply is limited, but it is somewhat controlled. Unstable angina, on the other hand, is much more dangerous. The pain is unpredictable. It can happen with less exertion, at rest, or even during sleep. Importantly, it does not go away with rest or nitroglycerin. The cause is often a blood clot that partially blocks blood flow in a coronary artery. Because it signals that blood flow to the heart is severely reduced, unstable angina is considered an emergency and can quickly lead to a myocardial infarction or heart attack. For nurses, recognizing the difference between stable and unstable angina is critical because unstable angina requires immediate medical intervention. Variant angina is caused by a spasm of the coronary arteries, not by a blockage from plaque. This type can happen even when the patient is at rest. The pain usually lasts longer than stable angina, and it often occurs at the same time each day, frequently at night. Because of the sudden vessel spasm, this condition is considered serious and needs close monitoring and treatment. The second type, microvascular angina, happens when the smallest arteries of the heart go into spasm. This type is especially challenging because the pain tends to be more severe and lasts longer than other forms of angina. Even though the larger arteries may look normal on testing, the patient can still experience significant chest pain due to these tiny vessel spasms. The key takeaway is that both forms of angina, variant and microvascular, are more unpredictable and serious than typical exertional angina, and they often require more specialized treatment and monitoring. When a patient presents with angina symptoms, several diagnostic tests are used to confirm the cause and guide treatment. The most basic test is the electrocardiogram, or ECG, which records the heart's electrical activity. This can show changes that occur during chest pain episodes. An exercise ECG or stress test evaluates how the heart responds when the patient is exercising. If a patient can't exercise, doctors may use chemical stress testing, where medications mimic the effect of exercise on the heart. Echocardiography uses ultrasound to visualize the heart's structure and movement, helping detect problems with pumping or valve function. For more detailed imaging, providers may order a cardiac CT scan or a cardiac MRI/MRA, which show the blood vessels and detect blockages or damage. Radioisotope imaging can also be used to show blood flow to the heart muscle. Finally, the gold standard is the coronary angiography, where dye is injected into the coronary arteries and viewed with X-ray. This directly shows narrowing or blockages in the vessels and is often used before procedures like stenting. The key point is that these tests help distinguish angina from other causes of chest pain and guide the safest and most effective treatment plan. Now let's review the main groups of medications used to treat angina. The first category is vasodilators, most commonly the nitrates. Nitrates, like nitroglycerin, work by relaxing blood vessels, which decreases the workload of the heart and improves blood flow to the myocardium. Patients often carry nitroglycerin tablets or spray for immediate relief of chest pain. Next are the beta blockers such as metoprolol, Lopressor, and atenolol, Tenormin. These lower heart rate and blood pressure, reducing how much oxygen the heart muscle needs. However, it's important to remember that non-selective beta blockers should be avoided in patients with asthma or COPD because they can cause bronchospasm. Also, beta blockers are not effective for variant angina, since that type is caused by spasm rather than exertion. Calcium channel blockers are another important class, including amlodipine, Norvasc, diltiazem, cardizem, felodipine, Plendil, and verapamil, Calin SR. These medications relax the arteries, reduce blood pressure, and help prevent coronary artery spasms, making them especially useful in variant angina. We also use antiplatelet medications, such as aspirin and clopidogrel, Plavix, to prevent clot formation inside the narrowed arteries. Finally, statins like atorvastatin, Lipitor, rosuvastatin, Crestor, and simvastatin, Zocor, are prescribed to lower cholesterol and stabilize plaque, reducing the risk of future heart attacks. Key points for using fast-acting nitroglycerin. Carry nitroglycerin NTG at all times. Keep NTG tablets tightly sealed in the dark container to protect from heat, light, and moisture. Maintain a fresh supply of NTG tablets, replacing it as needed or every 6 months for maximum effect. Use NTG before an activity known to cause chest pain. Tingling should be felt under the tongue when sublingual SL NTG tablets are used. Pour SL packet of powder under the tongue to dissolve without swallowing. Do not shake NTG aerosol canister before spraying it on or under the tongue, and close mouth immediately. NTG may cause lightheadedness. Sit or lie down when taking NTG if possible. Rise slowly to prevent falls, especially with sublingual spray. NTG may cause a headache initially for 1 to 2 weeks. Aspirin may relieve it. Nursing diagnoses for CAD and angina, acute pain deficient knowledge. When caring for a patient with coronary artery disease and angina, our top priority is to treat acute pain quickly and safely. First, always make sure the patient has IV access, since medications may need to be given rapidly. Next, assess and rate the patient's pain so we can evaluate treatment effectiveness. Administer oxygen to improve oxygen supply to the heart muscle, and give nitroglycerin, NTG, as prescribed to relieve chest pain. If the pain is not relieved after 3 doses of nitroglycerin, this is a red flag and must be reported immediately as it may indicate a heart attack. At that point, we administer aspirin as prescribed to reduce clot formation and provide an analgesic if ordered to help control discomfort. It is important to stay with the patient during these episodes, offering both physical presence and emotional support. Angina pain can be frightening, and reassurance helps reduce anxiety, which in turn decreases the workload on the heart. The key takeaway is that nursing care combines timely interventions, continuous monitoring, and emotional support to reduce risk and protect the patient's heart. Acute coronary syndrome, or ACS, is a broad term that includes both unstable angina and myocardial infarction, or MI. When we talk about MI, there are two main types. The first is a non-ST segment elevation MI, or non-STEMI. This type shows less dramatic changes on the ECG and usually results from a partially blocked artery. The second is an ST segment elevation MI, or STEMI, which is a complete blockage and shows a clear ST elevation on the ECG. STEMIs are more severe and require immediate intervention to restore blood flow. Another important concept is silent ischemia. This is a heart attack that occurs without chest pain. It often goes unnoticed until complications develop. Silent ischemia is more common in older adults and women, and it is frequently seen in people with hypertension or diabetes because nerve damage from these conditions may blunt pain perception. The key takeaway is that ACS is not always obvious. Nurses must stay alert to subtle signs like fatigue, shortness of breath, or weakness, especially in patients at high risk for silent ischemia. A myocardial infarction, or MI, is the medical term for a heart attack. It occurs when there is death of heart muscle due to a lack of oxygen. The pathophysiology behind this is a blockage in the coronary artery, which reduces or completely cuts off blood supply to part of the heart. Without blood flow, the tissue becomes ischemic and eventually dies. There are two major types of MI. A non-ST segment elevation MI, or non-STEMI, is caused by a partial blockage of a coronary artery. Blood is still getting through, but not enough to meet the oxygen demands of the heart. A ST segment elevation MI, or STEMI, results from a complete blockage. This is the most serious form, as no blood is reaching the affected heart muscle, leading to rapid and extensive damage. The main point here is that all MIs are emergencies, but STEMIs usually require the most urgent intervention, often immediate reperfusion therapy such as stenting or clot removal. Let's look at the coronary arteries, which supply oxygen and nutrients to the heart muscle itself. On the anterior view shown on the left, we see the left main coronary artery branching into two key vessels. The first is the circumflex branch, which wraps around the left side of the heart. The second is the anterior interventricular branch, also called the left anterior descending artery, or LAD, which runs down the front of the heart and supplies a large portion of the left ventricle. The right coronary artery can also be seen, supplying the right side of the heart and part of the conduction system. On the posterior view shown on the right, we again see the circumflex branch wrapping around to supply the back of the heart and the right coronary artery extending down the posterior surface. The key point is that these arteries are the lifelines of the heart. Blockages in these vessels lead directly to ischemia and myocardial infarction. For example, blockage of the LAD is often referred to as the widowmaker because it supplies such a large portion of the heart muscle. It's very important to recognize how myocardial infarction, or heart attack, presents differently in women. First, coronary artery disease and myocardial infarction are the leading causes of death in women. In particular, Black women are at even higher risk and face greater disparities in outcomes. Women tend to have a higher mortality rate than men after a heart attack. One reason is that women often wait longer to seek help, sometimes dismissing their symptoms as stress or fatigue. They also experience more complications after an MI compared to men. Another key point is that women often have prodromal symptoms in the month leading up to a heart attack. These warning signs may include unusual fatigue, sleep disturbances, or shortness of breath, symptoms that don't always get recognized as heart-related. During the actual event, women may have atypical symptoms instead of classic crushing chest pain. They might describe indigestion, back pain, jaw pain, or just not feeling right. Because of this, women are sometimes given less aggressive treatment compared to men. The takeaway is that nurses must stay alert to subtle or atypical signs of MI in women and advocate for prompt evaluation and treatment. Recognizing these differences can save lives. Diagnosing a myocardial infarction is based on both the patient's history and a set of diagnostic tests. We start with a serial ECG, meaning multiple ECGs over time. This helps us detect evolving changes in the heart's electrical activity that point to ischemia or infarction. The most important blood test is cardiac troponin T, CTNT, or troponin 1 is CTNI. These are highly sensitive markers of heart muscle injury and are considered the gold standard for MI diagnosis. Other markers include myoglobin, which rises very quickly after injury, but is less specific, and creatine kinase MB, CKMB, which is also used to confirm cardiac damage. We may also measure CRP or C-reactive protein as an indicator of inflammation that often accompanies coronary events. Electrolytes such as magnesium and potassium are checked as well because imbalances can worsen arrhythmias and complicate recovery. The key takeaway is that diagnosis of MI is never based on just one factor. It is a combination of the clinical picture, ECG changes, and cardiac biomarkers that confirms the diagnosis and guides treatment. AST elevation myocardial infarction, or STEMI, produces very distinct changes on the ECG. In the earliest stages, you may see peaked or hyperacute T waves, which are an early warning sign of ischemia. Very quickly, this progresses to the hallmark finding, ST segment elevation. The ST segment rises above the baseline, reflecting complete blockage of blood flow and ongoing injury to the heart muscle. As the infarction progresses, a pathologic Q wave may appear, showing that part of the myocardium has died and is no longer conducting electricity. This Q wave is often a permanent marker of past infarction. Finally, T wave inversion can occur as the heart muscle recovers, indicating ongoing ischemia. The key point is that ST segment elevation is the diagnostic hallmark of a STEMI, and it requires immediate emergency intervention, usually reperfusion therapy. The sooner the artery is opened, the more heart muscle can be saved. When treating a myocardial infarction, the primary goal is to restore blood flow to the heart muscle as quickly as possible. The standard is to achieve reperfusion within 90 minutes of arrival to the emergency department. There are two main approaches: invasive procedures and thrombolytic therapy. The first is percutaneous coronary intervention, or PCI. This involves inserting a catheter into the blocked coronary artery. A balloon angioplasty is performed to open up the artery, and often a coronary artery stent is placed to keep the vessel open long-term. PCI is the preferred treatment when available because it directly restores blood flow. The second option is thrombolytic therapy, sometimes called clot-busting drugs. These medications dissolve the clot causing the blockage. Thrombolytics are highly time-sensitive. For best outcomes, they must be given within 1 to 6 hours of symptom onset. After that window, the benefits decrease and the risks increase. The key takeaway is that time is muscle. The faster we restore perfusion, the more heart tissue we can save, and the better the patient's long-term outcome. This image shows the process of percutaneous coronary intervention, or balloon angioplasty. Step 1. The catheter is guided through the artery to the site of the blockage, where plaque has narrowed the vessel. Step 2. A balloon at the tip of the catheter is positioned within the narrowed section. Step 3. The balloon is then inflated, pressing the plaque against the artery walls and widening the vessel. This restores blood flow to the heart muscle. Step 4. The balloon is deflated and removed, leaving the artery more open than before. In many cases, a stent is placed during this step to help keep the artery open long-term. The key point is that balloon angioplasty is a rapid and effective way to relieve coronary artery blockage, and when performed quickly after an MI, it can save a significant amount of heart tissue. Insertion of a coronary artery stent. A balloon catheter with a collapsed stent is advanced to the location of a coronary artery lesion. B. The balloon is inflated, which expands the stent and compresses the lesion to increase the artery opening. C. The balloon is then deflated and removed, leaving the expanded stent in place to prevent the artery from closing. In addition to invasive procedures, patients with myocardial infarction also receive medical therapy to stabilize their condition and reduce complications. We start with oxygen, which helps increase oxygen delivery to the damaged heart muscle. Antiplatelet agents, such as aspirin, are given immediately to reduce clot formation inside the coronary arteries. Nitrates, like nitroglycerin, help dilate the coronary arteries and relieve chest pain by reducing the heart's workload. Morphine sulfate may be used for severe chest pain that is not relieved by nitrates, but it must be carefully considered because it can lower blood pressure and mask ongoing ischemia. Other vasodilators may be used to reduce afterload and improve blood flow. Beta blockers are often prescribed to slow the heart rate, reduce oxygen demand, and prevent arrhythmias unless contraindicated. Finally, antiarrhythmic drugs may be given as needed, since arrhythmias are a common and dangerous complication following an MI. The key takeaway is that medical therapy for MI is aimed at restoring oxygen, reducing workload, preventing clot progression, and controlling pain and arrhythmias. Please refer to Table 24.7 in your book. Myocardial revascularization refers to restoring blood supply to the heart muscle when the coronary arteries are severely narrowed or blocked. There are two main approaches. The first is percutaneous coronary intervention, or PCI, which includes balloon angioplasty and stent placement. This is minimally invasive and often used in emergency settings like a heart attack. The second is coronary artery bypass grafting, or CABG. In this surgery, a vein or artery from another part of the body is used to create a new route, or bypass, around the blocked coronary artery. CABG is usually recommended for patients with multiple blockages or when PCI is not effective. The key point is that revascularization, whether through PCI or CABG, is aimed at improving blood flow, relieving symptoms, and reducing the risk of future myocardial infarctions. When caring for a patient with a myocardial infarction, there are several priority nursing diagnoses. The first is acute pain, since chest pain is the hallmark symptom and must be addressed immediately to reduce anxiety and decrease cardiac workload. Next is decreased cardiac output, because part of the heart muscle has been damaged and can no longer pump effectively. Finally, we consider activity intolerance, since patients often experience weakness, fatigue, and reduced exercise tolerance following an MI. For patients recovering from cardiac surgery, many of the same nursing diagnoses apply, but there are additional concerns. Acute pain is again a priority, this time related to the surgical incision and chest tubes. Decreased cardiac output continues to be a risk because the heart is still healing and may not function at full capacity. And importantly, there is a significant risk for infection given the surgical wounds, invasive lines, and prolonged hospital stay. The key takeaway is that both MI and post-op cardiac patients require close monitoring, pain management, and support for cardiac function, but post-operative care adds a strong emphasis on infection prevention. Peripheral vascular disease, or PVD, is a condition that affects the blood vessels outside of the heart and brain, most often in the legs. It is especially common in older adults and in patients with diabetes because both age and high blood sugar damage blood vessels over time. Smoking and high cholesterol also increase the risk. There are two main types of PVD, arterial and venous. Arterial disease occurs when the arteries that carry blood away from the heart to the limbs become narrowed or blocked. This leads to symptoms like leg pain with walking, cold extremities, weak pulses, and non-healing wounds. Severe cases can result in ulcers or gangrene. Venous disease affects the veins that return blood back to the heart. When the valves inside the veins don't work properly, blood pools in the legs. This causes swelling, aching, skin discoloration, and venous ulcers, often around the ankles. The key point is that while both types affect circulation, arterial disease is about reduced blood flow to the tissues, and venous disease is about poor blood return from the tissues. Acute arterial occlusions are often sudden and dramatic. They are most common in the lower extremity. A thrombus, blood clot, adheres to the artery wall. Acute arterial thrombi occur with injury to an arterial wall, sluggish flow, or plaque formation secondary to atherosclerotic changes. Other causes of arterial thrombosis are polycythemia, dehydration, and repeated arterial needle sticks. If a thrombus breaks off and travels, it becomes an embolism that occludes an arterial vessel that is too small to allow it to pass. Causes of an arterial embolism are arrhythmias, prosthetic heart valves, Michigan, and rheumatic heart disease. Signs and symptoms: abrupt onset with acute arterial occlusion. Chronic arterial insufficiency symptoms may develop more slowly if collateral circulation is present. Symptoms depend on artery occluded and tissue supplied by artery. Gangrene may develop rapidly. The clinical signs of acute arterial occlusion are known as the 6 Ps: pain, pallor, pulselessness, paresthesia, numbness, paralysis, and poikilothermia assumes the environmental temperature. therapeutic interventions, anticoagulants, thrombolytics, thrombectomy, embolectomy. The purpose of the arterial system is to deliver oxygen-rich blood to the vascular beds. Anything that impedes this flow causes an imbalance in supply and demand for oxygen. Decreased nutrition, cellular waste accumulation, and development of ischemia occur distal to the obstruction. With increased debris and sluggish flow, thrombosis and embolism can become major problems. Peripheral arterial disease occurs when arteries in the legs become narrowed or blocked, reducing blood flow to the extremities. The symptoms often appear late in the course of the disease, which is why early detection can be challenging. Some women may have no obvious symptoms, making diagnosis even more difficult. When symptoms do appear, the most common is pain in the extremity or muscle cramping, especially with activity. This is called intermittent claudication, pain that occurs with walking and goes away with rest. Other signs include hair loss on the lower legs and ankles, and skin that becomes dry, flaky, or scaly. Thickened toenails are also common. Because of poor circulation, the skin often feels cool to the touch. Color changes are important. The leg may appear reddish-purple when hanging down, but turn pale when elevated. Finally, pulses in the feet and ankles are often diminished or absent, which is a key assessment finding for nurses. The main takeaway is that PAD causes pain, skin changes, and poor circulation in the legs, and nurses must assess for these signs to prevent complications like ulcers or gangrene. Raynaud disease is a condition where abnormal vasospasms occur in response to cold or emotional stress. These spasms reduce blood flow and cause temporary ischemia. There are two types: primary Raynaud's, which occurs on its own, and secondary Raynaud's, which develops along with other conditions such as collagen vascular diseases like lupus or scleroderma. It is most common in women who live in colder climates, and it mainly affects the fingers and toes, although it can involve other areas. Raynaud's typically progresses in phases. First, there is blanching or whitening of the digits as blood flow decreases. This is often accompanied by pain or tingling. Finally, the fingers become reddened as blood flow returns. Some patients also describe a blue or cyanotic phase before the redness. The key takeaway is that Raynaud disease is triggered by cold or stress, causes color changes in the digits, and can be a sign of an underlying autoimmune disorder if it occurs as secondary Raynaud's. Berger disease, also called thromboangiitis obliterans, is a rare but serious condition involving recurring inflammation and clot formation in the small and medium arteries and veins of the hands and feet. The exact cause is unknown, but it may have an autoimmune component. What we do know is that it is strongly associated with tobacco use, not just cigarettes, but all forms of tobacco. Because of this, the #1 intervention is complete avoidance of tobacco. Even small amounts can trigger flare-ups and worsen the disease. Some studies suggest that periodontal disease may also play a role in its development, linking oral health to vascular inflammation. This condition often leads to pain, tissue damage, and eventually gangrene, which can require amputation if not treated early. The image on this slide shows the severe consequences in the hands, with blackened necrotic fingertips due to lack of blood flow. The key takeaway is that Berger disease is preventable and manageable, but only if patients stop using tobacco completely and maintain good vascular and oral health. An aneurysm is a bulging, ballooning, or dilation of a weakened artery wall. Over time, the pressure of blood flow causes the vessel to stretch out, making it more likely to rupture. The most common type is the abdominal aortic aneurysm, or AAA, which occurs in the large artery in the abdomen. If it ruptures, it is often fatal, making early detection critical. Several risk factors contribute to aneurysm development, including atherosclerosis, hypertension, smoking, trauma, and congenital abnormalities. These conditions weaken the arterial wall and increase pressure inside the vessel. The risk also increases with age, which is why older adults, particularly men with a history of smoking, are screened more closely for abdominal aortic aneurysms. The key takeaway is that aneurysms are often silent until they become dangerous, and understanding the risk factors helps with prevention, early detection, and timely intervention. Aneurysms can be classified into 3 main types based on their shape and structure. The first type is the fusiform aneurysm. This involves a uniform, spindle-shaped dilation that affects the entire circumference of the artery. It looks like the vessel is bulging outward evenly on both sides. The second type is the saccular aneurysm. This is a localized pouch-like bulge on one side of the artery wall. It's more irregular and can sometimes rupture more easily due to the uneven pressure distribution. The third type is the dissecting aneurysm, also called an aortic dissection. In this case, blood actually enters the wall of the artery through a tear, separating the layers of the vessel wall. This is extremely dangerous and considered a life-threatening emergency. The key takeaway is that while all aneurysms are serious, dissecting aneurysms carry the highest risk of sudden death, while fusiform and saccular aneurysms can remain silent until they enlarge or rupture. Varicose veins are elongated, tortuous, and dilated veins that occur when the valves inside the veins fail to close properly. This allows blood to pool, increasing pressure and causing the veins to bulge. The exact cause is unknown, but there is a strong hereditary component. If a parent has varicose veins, the risk is much higher in their children. There are two types of varicosities. Primary varicosities develop on their own, often due to weak vein walls or faulty valves. Secondary varicosities occur as a result of another condition that increases venous pressure, such as pregnancy, obesity, or prolonged standing. The key takeaway is that varicose veins are not just a cosmetic issue. They reflect chronic venous insufficiency and can lead to pain, swelling, skin changes, and in severe cases, ulcers. Result of chronic venous insufficiency. Dysfunctional valves in venous system veins rupture, causing leaking of red blood cells into tissue, leg, foot, edema, brownish discoloration, hardened, leathery skin. Venous insufficiency is a chronic condition that happens when the valves in the veins of the lower extremities are damaged or weakened. These valves normally help blood flow back up to the heart, but when they fail, blood pools in the legs instead. This poor circulation leads to symptoms such as swelling, aching, heaviness, and skin changes in the lower legs. Over time, the constant pressure can damage the skin and tissues, leading to venous stasis ulcers, which are slow to heal and prone to infection. Venous insufficiency is more common with aging, prolonged standing, obesity, and in people with a history of blood clots or varicose veins. The key takeaway is that this is a progressive, long-term condition. Nurses play a critical role in teaching patients preventive strategies like leg elevation, use of compression stockings, weight management, and skincare to reduce complications. Lymphangitis is an inflammation or infection of the lymphatic channels. It usually develops after bacteria enter the lymph system, often through a skin wound or infection. It may occur in the arms or legs, and it is considered a serious infection because it can progress rapidly and lead to sepsis if untreated. The classic signs and symptoms include pain, a red streak along the affected limb, chills, and fever. The red streak usually follows the path of the lymphatic vessels toward the nearest lymph nodes. Treatment includes antibiotics to fight the infection, as well as heat, elevation, and sometimes pneumatic pressure devices to reduce swelling. Nursing care involves monitoring the site for edema and skin breakdown and ensuring prompt treatment to prevent complications. Common nursing diagnoses include acute pain related to infection and inflammation and excess fluid volume related to impaired lymphatic drainage.